Good evening, everyone, and welcome to the 9th webinar of the Cornea Club. This is our last session for this year, so we'd like to thank all of you for attending our webinars, for showing your interest. We had a number of world-known cornea experts from around the world sharing their pearls of wisdom over this last year on various cornea topics. We're planning to continue the next year, so please stay tuned, and hopefully we'll carry on with a physical meeting at some stage as well. Now, as always, we welcome your questions through the Q&A option at the bottom of your screen, and you can keep informed of our activities on our website, Facebook page, and YouTube channel. Now, for tonight's session, we have saved the best for last. The topic is on pediatric cornea with Professor Ken Nischal. So first, I'd like to introduce the moderator of the Cornea Club, Mr. Samir Hamada, who is the consultant cornea surgeon of the corneoplastic unit in East Grinstead, UK. And obviously, Professor Ken Nischal, who is very well known, very famous for his work on pediatric cornea. Mr. Hamada knows him very well. He used to be one of his trainees, as far as I'm aware. And Professor Ken Nischal is the chief of pediatric ophthalmology and strabismus at Children's Hospital in Pittsburgh. He's also a professor of ophthalmology. He's a pioneer of pediatric cornea transplants with expertise in genetic corneal disease. His main areas of clinical research are anterior segment developmental anomalies affecting the cornea, lens, and trabecular meshwork, and he has published widely on these topics. So I'll now hand over to Mr. Hamada.
Hi, everyone. Good evening. It's really a great pleasure to welcome Professor Ken Nischal. Well, he was actually my mentor doing pediatric ophthalmology, and he helped me to develop my interest in pediatric cornea. So definitely I learned a lot under his mentorship. He was one of the very few people who interested in pediatric cornea and dedicated a lot of their time, effort, research, and energy to develop. And it's no strange to call him the father of pediatric cornea. I learned a lot of him, and what's special about Ken, every time you listen to his talks, you learn something new. I mean, he never impressed me to teach me new things. Every time I call him for a second opinion on a case. So I'm sure you all will enjoy listening to his talk today. I asked Ken to give us a talk on topics in pediatric cornea, and he chose ocular surface in children. So this is obviously a common topic, actually interest all of us, whether you are pediatric or cornea or general ophthalmologist or trainee, optometrist, all of us see those children with ocular surface disease. So without further delay, welcome you, Ken, to the Cornea Club. Very great to see you here, and it's a privilege to us to have you on this session today.
Thank you, Samir. The honor and privilege is mine, and I think that you are doing yourself a disservice. I think maybe I was your mentor for about 10 minutes before you overtook me with your knowledge, but we learn from each other. That's the best way, right?
Okay, thank you. So we're going to start the talk, broadcasting your talk, Professor Nischal, and then we'll have a discussion afterwards.
Be involved with the Cornea Club, and I want to thank Samir Hamada very much for inviting me. These are my disclosures. Some of them are pertinent to the discussion today, and I will point that out when I feel it's relevant. So I'm going to talk about ocular surface disease in children. This is a really nice paper published about 4 years ago. And this is a really nice schematic. It's complicated, but it does go into the depth of the ocular microenvironment, you know, what it entails. And how I like to look at this is a little bit more simply, and that's what I like to look at. I like to look at the eyelashes, lid congruity, lipid, aqueous, mucin components of the tear film, corneal sensation, and corneal integrity. And I think that if every time you examine a child, you can see some of these things, it can help you understand what the ocular surface is doing. So if you think about the ocular surface microenvironment, there's the corneal epithelium, relies heavily on limbal stem cells. I'm not really going to talk about limbal stem cell deficiency today. Conjunctival epithelium also relies on limbal stem cells. The lid margins themselves, you know, you can get inflammation because of the meibomian glands. There's the congruity of the lid margin, there's the lashes, and in the tarsal conjunctiva, you can get fibrosis and you can get inflammation. It's impossible to talk about all of these things, but those are the sorts of things that you want to think about when you think you have an abnormal ocular surface or you have a child that's photophobic, has got punctured epithelial erosions, and trying to figure out why they may have them. So I like to use this schematic. I want you to remember that when we talk about the lids, think about the tarsal conjunctiva. I mean, that's the thing that rubs on the bulbar conjunctiva and the cornea a lot. So what I'm going to talk about really today is the tear film, and then I'm going to talk about things that affect the lids, the lid margin and the tarsal conjunctiva. And then at the end, I'm going to show you some rare conditions to show you how the microenvironment is disrupted by those. I'm not going to have time to talk about graft versus host disease. I'm going to make it fairly generic so that you can apply some of the principles that I'm talking about to everyday practice. So if we think about the tear film, you've got the microvilli of the corneal epithelium that hold the mucin, which holds the aqueous because of surface tension. And then you have the lipid layer coming from the meibomian glands to prevent evaporation of that tear film. This schematic isn't particularly accurate, but it does show you that in an adult, you know, what happens when you get a dry spot and why you get blinking. And so it's important to understand that there's this mechanism. I mean, when you look at a newborn baby, they don't blink. And they don't blink because the tear film is so robust that it's not evaporating. So the evaporation has an effect on your blink rate and has an effect on comfort. So in children, I evaluate the tear film by looking at the tear meniscus, the tear breakup time, the lid margins, and I look for staining for any punctate epithelial erosions. And I guess the first question is, what is the normal tear breakup time in children? And this is a study that I did with Sophie Jones, who did an MD with me at that time, in the late 2000s. And we looked at non-invasive tear film breakup time in normal children. We decided that the best way to do it was to do a non-invasive tear breakup time. It was done at Great Ormond Street, and we used what was the tear scope by Keeler at that time. And basically, you could attach this to the slit lamp, and you're able to see when the first black spot appeared, that was your nit butt, non-invasive tear breakup time, from the time the child took a blink and kept the eyes open to the first spot arriving on the analysis screen. So we looked at 24 children. Mean age at presentation was about 8 years, and the mean nit butt was 28.2 seconds. And there was no significant difference between nit butt between the right and left eyes. I think this is important, that the mean nit butt in children appears to be much greater than in comparison to recent adult studies using the same instrument, where the nit butt sort of varied between 11.2 to 16 seconds. Now, I think it's worth just stopping for a minute and talking about the tear breakup time. You know, it may be invasive and non-invasive. The commonest form of invasive is the fluorescein tear breakup time. I don't like to use that. The reason why I don't like to use it is that there's a lack of standardization of how much you apply. There's a large range of normal values. There's a non-reproducibility. There's an invasive nature of installation of the fluorescein. And this shortens the tear breakup time. And this is certainly true when the nit butt in children is compared to the published normative data of FT butt in children, with the former being almost twice as much as the latter. So I don't like to use the invasive fluorescein tear breakup time. I like to use the nit butt. It's interesting, you know, when you look at this, some studies that have recently been done about evaluation of dry eye. This was what looked like on the face of it a good study, but they used the Schirmer's test, and the tear film breakup time was fluorescein based. And what they came out with was that the only thing that was significant with normal children and children with BKC was the pattern of staining of the cornea. And I would respectfully suggest that maybe the assessments that they were using weren't going to give them the kind of data that would be needed to suggest that the tear breakup time was in fact important. At this moment in time, we've come through a pandemic, and I think it's important to remember that increased digital time, screen time, does have an effect on dry eye symptoms. There's also this idea of fatigue, which I'm not going to talk about, and increased accommodation and convergence. But this was a nice paper which basically showed very clearly that the amount of dry eye symptoms in adults sort of has gone up with digital screen use. And it's something we need to be aware of, you know, that this is an issue that is a very modern, very pertinent issue to us right now. So let's talk about the lid. I want to talk about the lid margin and then the tarsal conjunctiva. As far as the lid margin is concerned, I guess the most important thing is blepharitis in children. And these are the early studies that started to recognize that blepharokeratoconjunctivitis was a problem and that it was a disorder similar to that seen in adults, but that there was definitely an association with acne rosacea in the worst type, and perhaps also more importantly that there were some important differences. And the first time my group got involved with this, we wrote a paper about the visual outcome in corneal changes in children with chronic blepharokeratoconjunctivitis. And I really want to take you through this study. You know, it was 27 children with chronic BKC, mean age of presentation around 7 years. And I'll talk about the main symptoms in a moment. The mean best corrected visual acuity at presentation was 0.26 logMAR, and at last visit was 0.06 logMAR, so they tended to improve. However, about 30% of the whole group did not achieve acuity of 0.2 logMAR or better at their latest visit in the worst affected eye. And all these patients presented with corneal opacities and bilateral corneal involvement. We looked at these patients between 1999 and 2005, and I think we excluded children with significant systemic skin disorders like Epidermolysis Bullosa, lamella ichthyosis, or ones who had VKC or a history of atopy. I've covered this, but I think the important thing about this slide is that the mean age at onset of symptoms antedated the consultation by anything from 1 month to 5.5 years. And that's important. That some children with BKC are treated erroneously, either for allergic conjunctivitis or pink eye, or, you know, a sort of acute conjunctivitis. And therefore that can be, the diagnosis can be delayed because they're not referred to the appropriate team soon enough. So here are some sample pictures. You've got massive interspeciation here with buildup of dried meibum here. And this is the classic picture, the very dry looking eye, paracentral opacities. That's the whole point. In children, rather than seeing the marginal ulcer picture, you tend to see a paracentral scar. And for that reason, they can be misdiagnosed as having herpes simplex keratitis. Remember, in herpes simplex keratitis, that would be this bad, you would expect some sort of decrease in corneal sensation. So I always do check the corneal sensation in these children, just in case, you know, there is another pathology. Again, you can see the paracentral scars, and on the picture on the top right, you can see punctate epithelial erosions. So all of them had red eye, all of them had, well, 50% had photophobia, and a significant proportion had recurrent chalasia. So if you see recurrent chalasia, think meibomian gland dysfunction. And here we are, sample pictures of children from the study who had chalasia. 100% had posterior margin disease, and anterior margin disease was only seen in 22%. And these are, again, sample pictures. And you can see the rounding of the lid margin, the telangiectasia, the posteriorization, and the interposition of the meibomian glands. So if you looked at the change in visual acuity in affected eyes with time, you can see that from the first visit, to the most recent visit, the majority had an improvement in vision, but we had a few in which the vision did not improve. When you look at the magnitude of cylinder in this study with time in affected eyes, achieving vision of better than 0.2 logMAR, you can see that the CIL was always sort of less than 2 or less, and they tended to do well. If, however, the cylinder was large, then you see that the eyes tended to have a worse outcome. And that's not a surprise because, you know, there's the effect of amblyopia. If you look at the magnitude cylinder with time with corneal infiltrate, you can see that the magnitude of the cylinder is worse when there's a corneal infiltrate. And if there's no infiltrate, it's small, it's very mild. So why does the cornea become affected in BKC? Well, you get this paste-like secretions of meibomian glands, you get increased evaporation and dry eye. This leads to inflammation, corneal vascularization, scarring, keratitis. The paste-like secretions of the meibomian glands also result in hypercolonization with staph species. This results in hypersensitivity reactions to toxins, releasing pro-inflammatory markers, leading to lid incongruity, leading to increased evaporation and dry eye, and so the melee goes on. I mean, this is a protocol that we use at Children's Hospital of Pittsburgh, you know, and we divided this into mild, moderate, and severe. And I know Samir Hamada has done a lot of work on the grading of BKC, and I think his contribution has been phenomenal. I'm going to talk about the treatment, but I want you to know that, you know, there is this algorithm, and if anybody wants a copy of this, if you email me, my email address is kkn@btinternet.com. That's kkn@btinternet.com. Please email me, and I will share this with you. I want you to see that there is room for an examination under anesthesia if needed, and that's very important. So the treatment, you know, deal with the inflammation. Look, lid squeezing is important. The general anesthetic with lid squeezing and subconjunctival steroids is needed. Orally, I tend to use tetracycline and erythromycin. I know people talk about azithromycin. I have not found it to be as effective as erythromycin or tetracycline. Obviously, tetracycline we're using in the older children so you don't discolor their teeth. Topically, I really only ever use fluorometholone unless there's a flictenniolitis, in which case I will use prednisolone acetate. I like to do warm compresses. There's no point in lid scrubs, and the anterior margin disease is minimal. You know, it's 1 in 5, whereas all of them get posterior margin disease, and you really want to do warm compresses with massage to try and get those glands to open up. With the dry eyes, lubrication is very important. Remember, I showed you the slide, you've got to get rid of that dry eye to get rid of the inflammation. And I will use punctal plugs if necessary. If you see more corneal involvement than the lids suggest there should be, then I always think of Demodex infection. And I use tea tree oil shampoo, scrubs in this particular case, 1 drop in a sort of beaker of warm water. I do that for 4 weeks daily. Then I go to weekends for 4 weeks. I don't do any more than that because I find it to be toxic to children's eyes. Discontinuation of systemic therapy, even at low doses, often results in recurrence. And so I really tail this off slowly, you know, even down to 125 milligrams once a week for 3 or 4 months. The modified lid height is important, and I will use flaxseed oil if I've stopped erythromycin. Here's a particularly extreme case. You can see the meibomian glands are stuffed full of meibum, and when you do the lid squeezing, these kind of like strings come out. Now, it's not surprising then that when you look at the effect on the cornea, it's horrendous. You know, this child came to me with very photophobic, and unless you do the lid squeezing and get that paste out, how are you going to try and make this better? And that's extremely important. and integrated intraoperative OCT shows that the scarring is really almost full thickness. So this is a severe disease, and it's central, paracentral scarring. It's not marginal. So I've often been asked, you know, if you're using FML, which I used for a long time on reducing doses, you know, can you run into problems? So we did this study. Nina Matapsi was my fellow at the time, together with Aman Narang, and we basically showed that, you know, at the end of 7 years, there was no glaucoma, there was no cataract. So I feel that on low doses, like we're talking about, you know, you tail them down to once or twice a week, you don't see those complications, but you see an effect. I found that flaxseed oil or ground flax seeds are helpful. We've used them in children over the age of 4 years. And, you know, it's controversial in adults, but certainly there are studies that show it has an anti-inflammatory effect, may increase tear film. So we've talked about dry eye initially and then BKC. And I want to talk about lubrication. You know, artificial tears are important. And when you talk about artificial tears, always ask the patients if the child is sleeping with their eyes open. And here's a child who clearly has lag ophthalmos. You can see the staining. And this is just a schematic to remember that, you know, the position of the punctate epithelial erosions can give you a clue as to what's going on. And so you can get interpalpable staining in dry eyes. Lag ophthalmos tends to be the lower third, as you know. If it's superior, then think of BKC, SLK, superior limbic keratitis, floppy eyelid syndrome, and if it's diffuse, then just wonder if something else is going on, you know, like a viral or a toxic event. So it's difficult, you know, you want to know which one do you want to use. If the eye looks very inflamed, maybe you want to use something that will make the eye less acidic. Try and use non-preserved, not always easy. Think about the viscosity, because that can affect what the child sees, and they may not want to put them in if that's the case. Certainly at night, if you've got lag ophthalmos, then you can use an ointment. I like to use punctal plugs. So this is a study we did. We looked at 21 children. None of the children got infection, but we did have a spontaneous extrusion rate of about 25%. What I have found is that their symptoms, sore, irritated eyes, photosensitivity, excessive blinking, all improved. And this paper was published, I think, in the British Journal of Ophthalmology. And I think it's important to use plugs as an option. Children don't like to put drops in their eyes, and I tend to use the one with the flange stays on the surface. I like to try and use a bigger size than I might think the punctum will take, so it stays in there. And I warn the parents that the child may feel uncomfortable for about a day, and that's what they look like. I think it's been interesting. There's been recent work about trying to automate how you evaluate blepharitic conjunctivitis. And there's also been work about evaluation using non-contact infrared mammography and anterior segment optical coherence, basically showing that the volume of the cornea reduces and the glands basically are stuffed full when you have active BKC. I suppose it's a way of looking at how we might assess these children in clinical trials, although I think personally questionnaires are important, tear film evaluation is important, you know, measuring the lid margins or evaluating them, I think is important too. So I'm not sure that automation is here yet, but, you know, groups are looking at this. I think one thing that I am concerned about is that there was this study looking at the Cochrane database of systematic reviews, and these authors searched for randomized controlled trials that involved topical treatments of children up to 16 years of age with a clinical diagnosis of BKC. They only included one study from the USA that met the inclusion criteria. In the study, 137 children aged 0 to 6 years old with BKC were randomized to treatment in one of 4 trial rooms. With assessment on days 1, 3, 7, and 15. And my problem is that, you know, BKC is a chronic disease in children. 15 days of treatment is often not enough. a randomized controlled trial, an RCT, I've got a typo here at RTC, I don't think is an appropriate study mechanism. You know, the children that you're looking at are children who will suffer from amblyopia. They're, 0 to 6 years of age. And I think that real world data is much more appropriate with appropriate analysis, maybe even an individual meta-analysis. So please, I think we have to be careful that we don't apply RCTs where they perhaps don't always fit. So evaporative dry eyes in children, think about the symptoms that they get: excessive blinking, photophobia, recurrent chalasia can happen, punctate epithelial erosions, low tear meniscus, and then devise a strategy to deal with the problem. So we've talked about the lid, and I think what I'd like to talk about now is the tarsal conjunctiva, and this is really, really very important, you know, and I think allergic eye disease gets overlooked when we talk about ocular surface disease. These are all the different types of allergic eye disease, and GPC really is associated with contact lens wear. The pathophysiology, you know, only acute allergic conjunctivitis and seasonal allergic conjunctivitis are pure type 1 hypersensitivity reactions. VKC, vernal keratoconjunctivitis, and atopic keratoconjunctivitis are more chronic and more severe. And type 1 and type 4 hypersensitivity reactions are involved. And in these cases, conjunctival biopsies show massive infiltration of eosinophils and T cells, and that's important because I think the paradigm of how we treat VKC and AKC when it affects the eyes it needs to change. These are pictures of acute allergic conjunctivitis and seasonal allergic conjunctivitis. But when we talk about vernal, we're talking about onset normally under the age of 10 years of age, boys more than girls, these giant cobblestone papillae, thick ropey discharge, and the incidence increases with the vicinity closer to the equator. And there are mixed types. There's the tarsal, the incidence as you get closer to the equator goes up. You know, in America, it's 1.24 in 10,000. In Europe, 3.2 in 10,000. You know, going to up to 400 in 10,000 or 510,000 in Africa. VKC is supposed to resolve after puberty, but sight loss has been reported in 5 to 30% of cases. You get shield ulcers, infectious keratitis, corneal neovascularization, keratoconus because of the rubbing, limbal cell deficiency if the limbus has been involved, and with prolonged use of steroid therapy, you can get cataracts and glaucoma. So where are we in 2021? You know, there have been a couple of good papers, one by Gowrie et al. Showing that VKC poses a significant burden on the lives of patients and their families, you know, and greater awareness amongst clinicians is essential for early diagnosis and treatment to prevent potential sight-threatening complications. Wadwani and the group found that a total of almost 70% of caregivers were not aware of the symptoms of the disease, and 83% of caregivers are unaware of the side effects of eye drops used, especially steroids. So that's an important consideration. This slide is really important. You know, over the years, I've been involved in studies about VKC and AKC. There was a paper that I published with Dominique Ramon-Gignac in ophthalmology. Basically, if you have giant papillae with cobblestoning, look at the child's skin, see if there are any fissures on the lids behind the ear. Look at the lower lid, the double crease sign of Denier or double lid fold. And these things tip you off that this is AKC. This means this is a much more prolonged condition. It's not going to get better at puberty. And these are the ones where if you're not careful, you're going to get keratoconus, you can get retinal detachments, they can get cataracts. And it's really important to make that distinction. So the risk factors for worse visual outcomes with VKC are, you know, perennial VKC, limbal VKC, a history of corneal ulcer, severe baseline VKC grade at presentation, I'm going to talk about that in a minute, and higher recurrences of ocular inflammation per year. and of course, the lower the age of onset. All of these are risk factors for worse visual outcomes. I like the Bonini scale, you know, grade 1, grade 2, grade 3, and then you can see grade 4 with the limbus is involved and the tarsal condyles involved. And with each grade, you know, you can add a different therapeutic strategy. And I'm going to talk about that. The most important therapeutic strategy is allergen avoidance. We can talk about everything else, but avoiding the allergen that gives you the disease is really important. And when you do the treatment of VKC, you know, we've talked about the avoidance of allergens. You need to think about topical antihistamines, systemic antihistamines. Topical steroids have always been the mainstay, but you know, some of the calcium immunomodulators, cyclosporin and tacrolimus, are important to consider, and we'll talk about that a little bit more. In fact, it's interesting. There's been a couple of studies recently with 0.1% cyclosporin, and I will say that it is a product being made by Santen, and I have lectured about VKC for Santen in terms of the natural history of the disease and how important it is to try and control the disease. When you compare tacrolimus with cyclosporin, they, you know, and then topical antihistamines and topical steroids, if it's green, it means that you're getting a really good outcome. If it's red, it's like not such a good outcome in control of the symptom or sign. And you can see that when you look at the columns between tacrolimus and cyclosporin, there are more green boxes than there are between topical mast cell stabilizers, topical antihistamines, and topical steroids. So that in itself is a very visual way of showing that tacrolimus and cyclosporin may have a more important role than we necessarily have considered previously. Here's the problem. The problem is a shield ulcer. When you have giant papillae and you're getting that mechanical rubbing and epithelial toxicity, you get these shield ulcers. And there's a breakdown of the eosinophil granule proteins, enzymes are replaced, and this is what is epithelial toxic, and that's why you get the shield ulcers. So we've talked about the pharmacotherapy a little bit, you know, antihistamines, mast cell stabilizers, dual action drops, non-steroidal anti-inflammatory drugs, corticosteroids, and immunomodulators. And these are all the sort of topical drops that are available around the world. I like dual acting drops. I think Totifen is a good one. Olopatadine is a good one. Topical non-steroidals, we talk about those in a minute, and topical steroids. Antihistamines, what I find is the systemic ones are really important. And then when you go to topical ones, I like something that has a dual action. And here are some of the drops that have dual action. And I think those are, I like to use those. When you use a non-steroidal anti-inflammatory, just remember that if there is a defect in the epithelium already, you can get a corneal melt. So I normally avoid them. When you have severe disease, you've got to use prednisone, but you've got to look at the steroid response. I really haven't been impressed with chlormethalone or loteprednol, but they, in certain circumstances, they can be helpful. Problems with steroids, we know, you know, glaucoma and cataract. I find that supratarsal steroid injection using a 27 gauge needle, everting the lid, and you essentially, it looks like you're going to the bottom of the tarsal. Because the lid's averted, it's the top of the tarsal. I like to use triamcinolone and betazole or dexamethasone. I like to do that as a, pardon me, as a 50-50. And I do that so because I like the short acting as well as the long acting components. You know, you can get symptom relief within 1 to 5 days. I mean, look at the before and after pictures here. And here's another child. These pictures courtesy of an ex-fellow of mine in his Wong. And if you see here, when you inject, you really want to get that big bubble and try of the steroid and try and get the steroid to go right along the lid. And that's how effective it can be. You've got to be careful if you've got dark skin, that there have been some reports of hyperpigmentation. We've talked about cyclosporin. The lower concentrations, 0.05%, I don't find to be so effective. 0.1% according to the Vector study is effective. The higher concentrations tend to sting, so I'm hoping that the 0.1% will be tolerable and effective. Tacrolimus, what I do is, there's a drug called Protopic, which is tacrolimus, and in children with AKC, I get the parents to put it on the upper lid like that, and you find that a little bit seeps in and helps the ocular surface too. What's interesting is that if you look at a systematic review of all the drops that were used, the comparison among different classes wasn't really possible, but they found that what was important is that you were giving something topically to control the allergic eye disease and the VKC. And then what I think is you need a shift in being more aggressive with the immunomodulators being used earlier than perhaps we do at the moment. Here's another case, having all the therapy. You can see, miserable looking child, poor thing, and with the treatment, things do improve. I've never had to surgically excise giant papillae, but I guess if you're in areas of the world where you don't have all these drugs, it may be something that you're worth considering. What I will say is that if you have a shield ulcer and you have visible inflammatory debris in the base, you have to peel that off. If you don't, and if you have a plaque, if you don't peel the plaque off and the inflammatory debris, you will find that it will begin to melt through the cornea. So it's important to remove that. I don't do a surgical debridement. You could, and you could put amniotic membrane on. I've just found that if you are aggressive and take the plaque off early, get rid of the giant papillae with supradark steroid injection, start cyclosporin or tacrolimus, then it's important. If you're getting an ophthalmic suspension of tacrolimus, that's good. I can't get that in the United States. So I use the skin prep, as I said, just on the lid, and I find a little bit seeps in, and then I tend to use cyclosporin as well. I will use the steroid to get control of an acute situation, but I really want to get them off the steroid as soon as I can. I mean, and here's a case of a child who was given steroid drops by his GP in the United Kingdom, and pitched up with high pressures, cup discs, bilateral cataracts, visual fields that looked shot to pieces. He was on maximal therapy and was a steroid responder. And in this case, what do you do now? I mean, I did trabeculectomies, controlled the pressure, got rid of the cataracts, put implants in, and got his vision up to 0.16 logMAR right eye and 0.18 left. Pressure's controlled. But he has visual fields that are significantly affected. These are all the complications of VKC. I mean, you're aware of them, I'm sure, but keratoconus is a big issue, and you have to control the VKC if you're going to deal with the keratoconus. So this is our algorithm for treatment of allergic eye disease at Children's Hospital of Pittsburgh. Again, it's a very detailed evaluation of how we proceed when we see children with different components of severity. And again, if you'd like a copy of this, I'm happy to share that with you. Well, we've talked a lot. I want to sort of, if you like, tie things up and go back to this wonderful schematic. We've talked about the tear film. We haven't talked much about conjunctiva, which I'd like to do. And we haven't talked much about the effect of neurotization, or sensation of the cornea, and what effect it has on ocular surface. This is a child who unfortunately has Stevens-Johnson syndrome. And you can see that the meibomian, the lid margins are completely destroyed. There's cicatricial changes. The lashes are gone. The tarsal conjunctiva is fibrotic. And this is a problem because what happens is, I mean, here's the child. This was again Great Ormond Street. You can see the loss, the madarosis that he has. You get damage to goblet cells, you get conjunctiva, so your mucin is not produced. You get damage to limbal stem cells, and you get damage to lashes. And this has a profound effect in this child. In fact, look at this, has epithelial defect. You know, you're trying to manage this with amniotic membrane grafts. You're having to use autologous serum. You know, I haven't got time in this talk to talk about how you deal with graft versus host disease. It's a really, really difficult condition to deal with. So here's an example of an extreme situation where the palpable conj and the tarsal conj have been damaged, and this has a profound effect on the cornea itself. And again, in another case, you can see where it's a bit milder. You've got lashes that are metaplastic. They're not acting in the way they should do, and the lower lashes are turning in and actually touching the cornea and causing their own problems. In extreme cases, you know, we take for granted that the bulbar conj and the lids are going to move independently, and this is a case of epidermolysis bullosa where the lid is stuck to the cornea. And of course, that's a problem. The child can't blink properly. And, you know, we had to do a reconstruction. And once you do that, you can see the health of the ocular surface improve dramatically. So these are rare conditions, but I'm trying to show you that, you know, we take for granted that we have a normal fornix, that the bulbar conj, tarsal conj will move on top of each other. They don't always do that. And this is another case. Well, actually, it's the same case. It just shows the use of amniotic membrane and how it improved. And I really want to end with corneal anesthesia. And, you know, corneal neurotization has been popularized now. It's been around for a long time, but I think the newer techniques are helpful. And so many people are now doing it. This is a case of an 11-month-old female. She had left neurotrophic keratitis because of cerebellar hypoplasia and also trigeminal hypoplasia. This led to corneal anesthesia. She also had a poor blink reflex because of a concomitant facial palsy. And what you see is here, you know, you're seeing a neurotrophic ulcer and you're seeing hypopyon. This child presented like this because of a neurotrophic keratitis, and you can see the corneal vascularization. It's like a disaster. So, you know, the child was treated with fortified antibiotics, lateral tarsorrhaphy, and then we did corneal neurotization at the age of 16 months. This is what the child looked like. We took the sural nerve. It was passed from the supratrochlear nerve. It was coapted, passed underneath the skin of the forehead, passed through the lid, and then the vasicles of the nerve separated. This is a video which shows what I tend to do now is I tend to use a 27-gauge needle, pass the needle into the peripheral cornea, and then I'll take the you know, Vannas and just open up the pocket that I've created. And then I'll take the vesicle and push it into the peripheral cornea. You've got to be a little gentle and make sure you're not damaging it too much. But I tend to use a cannula just to push it in. You can see the little hole that I've made in the peripheral cornea there. I'm just taking the vesicle and just passing it in. Like that. And you do that, you go all the way around and do that. Okay. So the child has done really well. The sensation has returned, the corneal epithelium is healed, and I use OCTs of OCT, and in fact published OCT data showing that the palisades of VOC actually reform, become much more robust when you do this. And when they're robust, then you like to have good limbal stem cells. And you can see the epithelium looks much healthier now as well. So we're managing the amblyopia. We were thinking about doing a corneal transplantation, but in her case, given the social circumstances, we may just opt for an optical iridectomy. So, the ocular surface in children, it's an area that's ripe for exploration. I think real-world data is paramount. Developing instruments that are child-friendly is really important. And I think understanding how children may present, with excessive blinking, photophobia, all these are different to how they might present in adults. So on that note, I really want to thank you very much for listening, and I look forward to our discussion.
Oh, thank you so much. This is an amazing review of ocular surface disease in 45 minutes. I don't think anyone could do a better job. This is congratulations. And I have to say, you managed to squeeze everything innovative and new. Your algorithm are amazing. Can I ask you, are we okay if we publish your algorithm on our Cornea Club website? Because I think that's very useful to all the cornea specialists and pediatric as well.
No problem.
Great. And I'll just start with a few questions, and we have questions from the audience, if you don't mind. You talk about corneal neurotization. We do that. We're lucky to do it at Queen Victoria Hospital. Do you use any glue, or do you have to stitch those tunnels? I mean,
no. So I started off stitching, and then I just found that if you push it in, with using a 27 gauge needle, and then you push it in with the cannula, it just stays. I haven't had any that have popped out. So I have not used glue. I've just sort of pushed it in and mechanically forced it into that peripheral cornea.
Excellent. Amazing. Looks like it's very stable as well and easy. Make life easy. Okay, I'll go back to the start, really. People say, do children get dry eye? That's like a question. What would you say?
So I think that the symptoms that children present with dry eye are not the symptoms that we're used to in adults. Adults talk about their eyes being gritty, that their vision gets blurred. Well, children don't understand what gritty means. So you often see children doing funny things. If you see a child blinking excessively, like that, you have to think about a dry eye before you think they've got a nervous tic. In fact, one of my fellows has been writing this up. We have about 11 children, some of them from London actually, and some from here, who were investigated for neurological tics, and then came to see me and were treated with lubricants or punctal plugs, and their tics disappeared. It was a dry eye phenomenon. So I think that the symptoms are different. I think children also complain of blurry vision, but they do it by failing to do their work. They fail to read. They don't say, I've got blurry vision. They just don't do what they're supposed to do. So they get taken to see an eye doctor, whether it's an optometrist or an ophthalmologist. And I think one of the things is, I am noticing post-pandemic so many more children who are asymptomatic, but their tear meniscus is hardly there. And then when you say to them, have they been having reading difficulty? The parents will say, yeah, doesn't like reading as much as they used to, will sit on the screen, but doesn't like reading. And I think maybe the eyes get blurred. The analogy I give is in the summer, when you have a windscreen in a car that's got no water and you've got the wipers going, everything gets blurred. And that's what happens, I think, to these kids. So I do think dry eye is a problem. I think that children are just more stoical. They just put up with it because they don't know any better.
So you said children, in particular newborn, they have a robust tear film. I mean, why do you think it's robust? Are you talking about different meibum maybe in childhood? Is it thickness? Tear time was longer?
But see, this is it, right, Samir? If you and I could figure that out, we could make a lot of money by creating a new artificial tear. But this, yeah, so if you look, there are a couple of studies, actually, Japanese have done them, where you look at the tear film constituent in newborn infants, and their meibum is different, the osmolarity is different, and the mucin is different to the mucin that we have. It's much more cohesive than the mucin that we have.
So that means actually the reference point when people talk about 10 seconds tear breakup time, if it's 10 seconds in child, might be too low, isn't it?
Yes, exactly.
Yeah,
exactly. And in fact, there's a wonderful doctor, cornea specialist called Sophie Jones, who did her MD with me when I was at Great Ormond Street. And initially, when we looked at epidermolysis bullosa children, we were getting breakup times of 14 seconds, which is normal. And she and I were both confused. And she did the work on the nitput in normal children and found it was 28 seconds. And it was only when we found that we realized that these children with epidermolysis bullosa had relatively dry eyes. And that helped us with their treatment.
Yeah, actually, Sophie Jones is with us today as well. She's listening now. Yeah.
Oh.
So
she's at East Grinstead as well?
No. No. Obviously, Sophie is a consultant in King's College Hospital, one of the top cornea specialists in London. Okay, can I ask about? You mentioned briefly something about tear breakup time not important in dry eye. Or you were referring to someone's statement that tear breakup time is not.
No. So I was referring to the fact that I don't like fluorescein tear breakup time because it's an underestimate of the true tear breakup time. When you do a nit butt and compare it to an FT butt, the nit butt is always much longer than the FT butt in children, and so I don't like to use that. And in this study, it was a nice study, but I felt that they found the only difference in the evaporative dry eye state between children who had BKC and children who didn't was the fact that they had corneal staining. But the tests that they were using for the tear film, I don't think are appropriate for children.
Okay, thank you. And in terms of management, how do you tell the parents about massaging the eyelids? Because I find sometimes difficult. I mean, even adults, the challenge, isn't it? How about with children?
Yeah. So I tell them to use a warm compress, so like a towel under a hot water tap. When it's not too hot, put it on the eyes for about 30 seconds. And then I ask them to roll the upper lid and roll the lower lid, like the toothpaste pointing downwards and toothpaste pointing upwards. So you're trying to roll that paste out. And I tell the child that if mommy and daddy do it properly, the vision will be blurry because all that paste comes out and then they are a bit blurry.
Good, nice one. You said you use topical tetracyclines? Is that available in the States?
No, oral tetracycline if they're over the age of 12.
Okay, but you don't have access in the States for the we
have azosite, but again, I haven't found that. I've only anecdotally not found it to be effective, but we're going to try it out in a sort of a controlled trial soon on some children.
Perfect. How common is Demodex in children? Do you see many children with Demodex?
Yes, I would say 20%.
Wow.
25% of all the children in Western Pennsylvania have Demodex. I don't know if that said something about Western Pennsylvania. We have a lot of Lyme disease as well, but I see a lot of Demodex.
That's very interesting. Okay, so now this is a very difficult question. It's about use of steroids in ocular surface disease.
Right.
Because I mean, we both know we are in referral center. We see patients refer children with the corneal disease, various disease. And I see there is a lot of random use of steroids. Sometimes there's no direction. Could you just, I know it's a big topic, but just want a little bit of guidance from you, direction to people who want to think about using steroids in children in ocular surface inflammation. Do you have guidance on what's where you think it's safe, how long, what steroids you want to use, and you talk about tailing off steroids, etc.
So I think, look, the most important thing is the pathophysiology. If you, whatever you're looking at, try and understand the pathophysiology, and you'll understand that what the intervention of the steroid is going to do. So let's talk about blepharokeratoconjunctivitis. If you're only going to use a topical steroid for blepharokeratoconjunctivitis because you've got inflammation of the conj, you've got telangiectasia, post-steroidization, and the eyes are red and sore, then the one you want to use is FML, because in the presence of an intact epithelium, it's not going to penetrate the eye, right? So your risks of complications are lower. The only time you want to use prednisolone in those conditions, or dexamethasone, is if you have an acute flicten or flictenulitis, in which case the FML is not going to suppress the inflammation fast enough. And that prednisolone dose should be over 2 weeks, see them, and then switch to FML. Now, if you have vernal keratoconjunctivitis, what I'm trying to say is, with the VECTIS study, and if you haven't read it, it's worth reading, VECTIS, V-E-K-T-I-S. The VECTIS study used cyclosporin 0.1% as an initial treatment for VKC, and no child who had that as initial treatment needed steroid as a rescue treatment. So I think that the 0.1% is tolerable. Again, I have lectured for Santen, but I lectured for Santen once I had read the papers and saw how good this was, and lectured on the natural history of the disease, not on the drop itself. But the evidence is there that this could be a game changer. So if you're going to use steroid to acutely control, you want to do it in a short term. You don't want to give it to them and say, see you in 2 months. If you give the steroids, they have to be seen in 2 weeks. A, to check for steroid response, and B, to check on the response that you're giving, and then add an immunomodulator.
Great notice here, great observation. One of the problem I can see here is there are a lot of practitioners, they keep doing the steroids. It's becoming like a routine, and sometimes given to the patient to use it as and when, which I'll probably disagree. I'm not sure what you think.
Yeah, I agree. Yeah, I agree with you. They shouldn't do that.
No. Okay, good. Probably my last question. There are more questions from the audience. When would you use the punctal plugs? At what stage in the disease course you said, okay, I'm going to do the plugs now?
Okay. Do not use the punctal plugs when there is acute inflammation, because if you do that, you trap all the cytokines, all the interleukins, and the inflammation just gets worse. So you have to get on top of the inflammation. And once you've got on top of the inflammation, now you use the plugs as a dam to dam up a reservoir of tear lake, so that even if there's more evaporation, there's more tears to evaporate and the surface stays wet.
Excellent. Thank you so much. Great observation. I'm glad some of the things you put are really important messages. Right. I'll pass it to Artemis to ask you the remaining questions from the audience.
Thank you very much. Actually, I also have a question about the neurotrophic keratitis in children.
Yes.
Do you have any experience? Have you used insulin drops? There are some studies about use of insulin drops in adults with good outcomes. Have you had any experience in that with children?
No, I have not. I've read the papers. See, the ones that get to me that are really bad, I'm like, I just have to neurotize you. There's no point waiting to do anything else. And I will often do a temporary tarsorrhaphy until we get them to neurotization. I don't have any experience. I think if it's something worth trying, but I don't have any experience. And you know, I think it's called Synergen, which is the recombinant. Is that the name of the?
Synergermin, yeah.
Synergermin, that's right. Again, I don't have any experience in the sense that I wouldn't use that. It's very expensive. I would rather. I know there are a couple of studies, or at least I've heard of studies where they're doing the neurotization and using the Synergermin at the same time to try and accelerate the neurotization. But again, I have no experience.
Great, thank you. And there are some questions from the audience. So first one is, what is different, special about recurrent corneal erosions in children?
Okay.
And what is different about treatment approaches in this topic for children as well?
I think, look, the first thing is that the age of the child, if they present with these episodes where they're screaming, that's how they do it. They scream, the parents say they'll wake up in the morning or in the middle of the night screaming. You try and get a history to see if there was a foreign body, you know, a fingernail or a twig in the eye, the normal thing. If there's a clear story of trauma, then you do it the same way, you know, ointment at night, at least for a month, to see if that will improve things. Unfortunately, the younger the child, the more difficult it is to put the ointment in. So what I say is that if after, let's say, 2 or 3 weeks, after 4 weeks, the parents are saying we can't get it in, it's not getting any better, exam under anesthesia. That's really important. Do the exam under anesthesia, have a look and see what's going on. If you have an integrated intraoperative OCT, it's even better. You can see the area that's affected. And you warn the parents that if that's the case, I'm going to debride and I'm going to do tiny little punctures just in that area. You've got to do that in one go. It's different to adults. I don't have an excimer laser, so I can't do any sort of phototherapeutic treatment. But I've had to do that twice in 10 years here at Pittsburgh. And I put a bandage contact lens on, and I put them on moxifloxacin. And then we take the bandage contact lens off after 3 days. And those 2 cases have done very well. Now, if you can't get a family history, if you can't get a history of any event, then please think about whether this is going to be a corneal dystrophy. And, you know, the ERED, the inherited recurrent erosion dystrophy, you know, COL17A1 is the cause. Now, the big difference in my practice in the United States compared to the UK is I had genetic counselors working for me. And I can get genetic testing. I can do a panel of all the dystrophies like that. And almost all of the insurances will cover it. So I have access to molecular diagnosis, and that makes a big difference. Again, the key here is to take the child to the EUA. Because once they're asleep, you know, and you can examine them, especially if you have an OCT or a handheld slit lamp, you can see if there's something else going on other than just a recurrent erosion. And I hope that's answered the question for the person who asked it.
Thank you. And further to this, I think that's probably
yeah, Ken, I agree with you. I mean, one of the issues, even in the UK, the access of excimer laser in general anesthesia for children is challenging, to be honest. And a lot of times we end up doing just alcohol delamination for those children with recurrent corneal erosions, provided we establish this is ABMD or EPMD disease. Yeah.
Yep.
And I think that the next one, again, regarding this topic is, what would you recommend parents to do in terms of getting good medical help for their child? So which medical specialists are more likely to be helpful? Are pediatric ophthalmologists generally well-versed in treating recurrent corneal erosion, or is a pediatric cornea specialist the best person for them to see?
So look, in the United States, it's such a large country. You get to see whoever can see a child, whoever can examine a child well, and that's a pediatric ophthalmologist. In the UK, I think there are enough centers with enough people with an interest in cornea in children that you see one of those specialists. You know, if you look, when I started at Great Ormond Street, there was no pediatric cornea specialist in the UK. Shiraz Daya used to do some, and he encouraged me to take on the mantle. But now, you know, you've got Sas Biswaz in Manchester, you've got Samir in London, you've got Will Moore, you've got Manoj in Birmingham. I'm sure you've got many other people I don't even know the names of anymore. So I think the answer is you try and get to a pediatric ophthalmologist, and they should know someone who has an interest in cornea if they don't know themselves. But even some optometrists are really good as well. So, you know, it's worth just seeing an eye specialist.
Good, thank you. The next one is about corneal neurotization for congenital corneal anesthesia. Is it indicated?
Yeah, so I know Mina very well. So the thing is that if it's unilateral, it's easier to do. I mean, there are reports of bilateral congenital corneal anesthesia, and those are really difficult because if you've got no sensation coming with complete trigeminal aplasia of both sides, then that's a problem. But when it's unilateral, you can do it. So we've done it. Maybe we should publish. I didn't realize people thought you couldn't do it for congenital corneal anesthesia. In fact, I'm doing another one next week, another congenital one, but unilateral.
Okay, perfect. The next one is there any role of using Botox to induce ptosis rather than performing tersography, especially in children?
So, great question. What I would say is this: the trouble with Botox-induced ptosis is that you can give the child or the adult an induced hypotropia, and the hypotropia may not go away when the ptosis gets better. So I learned this the hard way. So I don't give the injection in children anymore. In an adult, if I know the vision is never going to be good, I will give it because the hypertrophy makes no difference. So the answer to the question is I do not do it in children.
Good, that's
now,
very clear.
The only time you might consider is if a child is really ill, you can't get them into the OR, they won't take a local, and so you sedate them and then you give them the Botox injection. And I would give 25 to 35 units under that circumstances, and that's the only time. And oh, Sophie Jones is asking a question. Hi, Sophie.
Yeah, indeed. This is the next one.
Yes.
Ms. Jones is asking, have you seen children with BKC who present with a perforation?
Yeah.
There's a 14-year-old with severe BKC who has presented to clinic with a large lesion and perforation.
Yeah, so Sophie, I published a paper. I thought it was with you, maybe it wasn't. It was called Management of Corneal Melt in Children. And we basically said that rather than doing what we do in adults, waiting, that when you have a corneal melt in a child or a perforation, you need to go in acutely because the younger the child, the inflammatory response is so scary, so terrific, that if you wait, you get too much damage in the eye. So in that paper, it was published in Eye, I have an example of a child with severe BKC. Donald Tan published a paper with 7 or 8 cases who had that. And the reason is the incessant inflammatory cytokines and interleukins that are released causing lysis of the corneal stroma.
We published as well when I worked with Cyrose from Birmingham.
Yes. Sorry, yes.
We done the grading and we saw those cases. Actually, those are Caucasian because that's opposite what other in literature.
Yeah.
Where with the cornea melt, vascularization and scarring, really difficult. They need immunosuppression treatment, etc. But I'm glad, Ken, you're talking about early intervention because I think one of the problem I face it when we see those children coming to pediatric cornea clinics. They're already in advanced stages. They now have a scarring. You have to work around their management of clarity of visual axis, the keratoplasty. So really, we should not underestimate the inflammation and should be really tackled early in stage of disease. Thank you.
Great,
Artemis?
thank you. And I think there is one about the use of topical ointment of tetracycline in children under 12.
Yeah, there's no evidence that if you use topical tetracycline that the doses in the blood will affect the dental buds. I don't use it. I don't like to use ointment in BKC because it clogs up the gland mouths even more. But yeah, there's no evidence that the topical ointment tetracycline has an adverse effect on the teeth.
Great, thank you. I think
the last one
is about a list of pediatric ophthalmologists in the US and the UK.
Yeah, so I don't know about the UK. I'm sure there's something at the Royal College of Ophthalmologists.
Yeah.
In the US, you go to the AAPOS website and it says find a pediatric ophthalmologist. It's not difficult.
Great.
I would say for the UK, with Royal College, obviously, but the Cornea Club website, we're going to publish list of people who's interested in pediatric cornea as well, on top of the adult cornea, yeah.
Perfect.
Yeah.
Great. I think that's all from the audience. We have actually overrun, and they're all thanking for your great presentation.
Oh, it's nice to see Samir as well. All these friends. Wow. Okay.
Thank you so much. I have to say this is one of the. I'm sure this is recorded and is going to be published on YouTube. Normally, we have a lot of people reviews on the YouTube and on Facebook. But I have to thank you again. This was an amazing overview. I wish we could have more time. We can always talking to you, interesting, a lot of ideas, a lot of thoughts, and many innovations. So thank you so much.
No, thank you for inviting me.
Thank you, and thank you for everyone for attending. So as Mr. Hamada said, you can find this episode recording on YouTube and on Facebook as well. And we look forward to welcome you to the next episode, which will be in January. So please stay tuned for the date and the topic for next time. So good night, everyone, or good afternoon, wherever you are.